Yeah, Tom is going to introduce.
Okay.
All right, morning, everyone. This morning, we're going to have a little bit of a counterpoint on the best surgical approach for total hip arthroplasty. And I believe Chris Whalen is going to advocate for the direct anterior approach, and Jeremy is going to counterpoint with the posterior approach. So I will pass this on to whoever is going to take the stage first, and after we're done, hopefully there'll be some questions that we can field from the audience. So welcome, everyone, and I'll turn it over to whoever's going first.
I think I was going to go first unless Chris had some desire to. So if I can share my screen.
Are those your jammies there?
No, I had my scrubs on because I was assuming that we were going to have some sort of hip fracture today that had to be done. Can everyone see my screen?
Yeah.
Yep.
Perfect.
So let's swap that. So we're going to be doing the anterior versus posterior approach. I'm Jeremy. If I haven't met anyone, I'm from Virginia. Did my residency at the Mayo Clinic in Rochester. So kind of an outline, we're going to do the posterior lateral approach, history, indications, and contraindications, a bit on the technique, and then results. So this is kind of like when I was given this topic, I was trying to think of how to make it a little more interesting. This is Dr. Brown, and he does the anterior approach more often these days. This is the other Dr. Brown, who does the posterior approach, and I thought of them kind of like Biggie and Tupac, or if you're into cars, the Lamborghini, the Ferrari. And so we'll kind of try to figure out which one is better at the end, but they may both be just really good. So the posterior lateral approach, it was first described back in 1874, and it's transitioned to what we have today, mainly from the approach aspect. The incision aspect has gotten smaller. We've taken down the external rotators and things like that. It's universal, it's simplistic, there's ease of dissection, it preserves the abductor musculature to a large degree, and when we release the external rotators, we repair them now, but without that, there has been increased dislocation risk historically and still today. Worldwide, it's the most common approach, but as we can see, the trend from the direct anterior approach is increasing. It's actually increased 28% since 2009. And the most recent ACUS polling has shown that it's back up to 40% and even 45% in 2020. So there's interest in the direct anterior approach that's increasing. For indications, you can pretty much do this for anything, complex or primary total hips, revision total hips. There's ease, the incision, exposure, extensibility. You can do osteotomies fairly easily through this, and a whole host of other procedures, not just arthroplasty. Contraindications are relatively limited. You wouldn't want to do an IND of a native septic hip or a pediatric hip through the posterior approach for blood supply disruption. But to a large degree, the posterior approach is the workhorse. So we're going to briefly go through the technique and then kind of do some counterpoint with the direct anterior. The setup is all standard hospital equipment. You don't really need a specialized bed for this. You can use a host of hip positioners, but really you want a stable pelvis with the butt crack basically in parallel with the floor. And you want these fastened so that when you're moving the hip and the pelvis doesn't move in the operating room, you can hit your targets. Pad all bony prominences, axe roll, etc. So what about the direct anterior approach? You need a specialized bed. You got to have some way to get the femoral shaft up, whether you're using the HANA table or if you're going to basically take off the bed and do extend the lower half of the bed for on the table direct anterior. People got to know what they're doing, really. This can't be the scrub tech, the nurse circulators that are coming in for their shift that they basically say, hey, I don't really work here. hopefully this goes well. And you hear that a lot, especially in different hospital systems. So this needs to be a solid team that can figure this stuff out for you to have a good surgery. There's a pretty funny Steve Carroll video on the direct anterior approach that I urge you to look at in your free time that Dr. Brown posted to me. But he basically thought that he was on a chicken skewer when he was getting his direct anterior approach. So here's the workflow. I'm not going to go through this in depth, but basically it's a curvilinear incision along the greater trochanter, extending the femoral shaft and going on along the posterior third of the troch. And this is a different type of incision. This is a straight one, but this, for demonstration purposes, is showing you the greater troch and the incision. And this is how small you can basically make it if you want. So you can have it 10 centimeters or less. And so it can be minimally invasive. And so you go down through sub-Q, find your IT band, make a split in that, and kind of identify through that split in the IT band where you are, and you want to kind of be able to feel the gluteal sling. So once you feel that on the posterior aspect of the femur, you can make your dissection proximally, and you really just want to go through that thin fascial layer proximally, and then split the gluteus maximus with your fingers. And you can really easily do this without any cautery and minimal disruption of those soft tissues. So there's that demonstrated there. And as you go deeper, you'll start to see your external rotators, and you can kind of swipe some of that fat tissue off of your external rotators, and then you can start to see your trochanter, your gluteus medius. And then as you put an elevator there, you can see your gluteus minimus underlying, and then underneath that, you can see your capsule. Sciatic nerve is very close, so you have to be cognizant of this and not go in, like a bull in a china shop, but it's fairly safe if you do the right maneuvers. Here's the gluteus minimus being lifted up with a Cobb elevator to identify the capsule. And then once you identify that, you can basically start taking down your short external rotators, either in layer or with the capsule, like so, and have exposure to your acetabulum. You can put a bunch of retractors in here if you want. Some of them can be basically self-retaining. If you have a Homan, you can mallet into the acetabulum peripherally and have good exposure here. And it's pretty much full 360-degree exposure. This is one of the big advantages of the posterior approach. There's no question about it. You have better exposure. And then exposure of the femur, you can do some releases more posteriorly down the quadratus. You want to flex the hip up, and then you put the leg in a position to where the bottom of the foot or the sole of the foot is facing towards the ceiling. You kind of put that under your armpit and get a Mueller retractor in on the back to lift the femur up, and you get quite good 360-degree exposure. You can identify the lesser trochanter. And it's just a good check on everything, because you can see everything and identify your version, your starting point. It's very good exposure there. And so here is kind of a view of the muscle sparing direct anterior approach. You can't see a lot. You can't always see down to your lesser trochanter. It is a little bit of a feel and a technique driven approach, in that you have to do these posterior releases that you can see on the right. Once you get that retractor in the back under the trochanter, you have to do more releases of the superior and superior posterior capsule. And there your short external rotators are, and they're not labeled in the operating room. So I do think that a lot of surgeons may get into that area, and whether that is a big deal or not is debatable, but it's not necessarily completely sparing. You can also make the posterior approach into extensile approach. Here you can see an extended osteotomy, and so you can really get these stems out. So for revision procedures, I don't think that it's a debate that the posterior approach gives you much better visualization and to get these well-fixed stems out, which are often the case. Extensile approach from the front, now we're just making a bigger incision. So cosmetically, I don't see that there's any advantage here. Now you got a big lazy ass incision on the front. And you can see by this little picture here that there's some dangers in this area as you go and have to go up and down the femur. For the posterior repair, this has been a big issue throughout the years with the posterior approach. Any debate is talking about dislocation risk, and I think that there are multiple different repairs. This is the one that Dr. Quay likes. I actually kind of like this one too. And basically, you make drill holes and pass a suture passer through these. That way, you can get the external rotators directly up underneath the trochanter and anatomic position. There's another approach that Dr. Brown and one of my mentors, Dr. Pagnano, made and published, and this is a fairly easy approach, and it provides a nice sling of soft tissue that really cradles all that tissue in the back that was originally disrupted. And this is basically repairing it to the superior capsule. And I think that this one is very tight as well, especially when JB does it. So is there a bias with the direct anterior approach? I think the demand is increasing not only in patient perceived benefits and outcomes, but resident fellow education and employment opportunity. There's an analysis here through this study that industry websites are proposing, the direct anterior approach is the best approach, and it's heavily biased. And interestingly enough, over 20% of the ACAS members promote DA on their internet and claim 9 times the benefit over potential complications. But there's rare reference to kind of peer-reviewed literature to support this claim. In terms of results, I'm going to try to hit the main stuff because this can be overbearing to some degree with all these results here. But in terms of recovery, this study showed no difference in clinical outcomes. The DA had more femur fracture, and we'll get into that in a little bit. This is Dr. Taunton, who did his residency at Mayo and fellowship at Ortho Carolina back at Mayo now, is kind of is a very big advocate of the DA approach. But he did the study with Dr. Pagnano, who is more of a mini posterior approach now, and basically found that here are the results: 10 days versus 15 days to discontinue walker, all gait aids 17 versus 24 steps per day. The mini posterior had obviously less there, but what are we really considering important? And when you kind of look at these things, it's a 4 or 5 day advantage with a direct anterior approach. And these were 2 big studies that are heavily cited. There's prospective randomized study by Barrett. This is another one that's heavily cited in 2013. No difference past 3 months is the kind of the key that I wanted you to look at there. No difference past 6 weeks in this next study, but there's a 10% fracture loosening during the learning curve. And I think that's still important to consider the learning curve, because not everyone is an arthroplasty surgeon that are doing these cases. And if the learning curve is 50 or 100, it may take that person a while to get there. Here's another study. This is a randomized controlled trial, no difference in functional parameters or patient reported outcomes at 6 months. So I will give it to the direct anterior approach. Most evidence is pretty conclusive that initially within the first 2, 3 weeks, 6 weeks, 3 months, that the direct anterior approach may have faster recovery. But to that degree, I'm not quite sure that it's that big of an advantage. This study had an 83% incidence of lateral cutaneous nerve neuropraxia. I don't think that's a big deal, but that's something that we need to be telling patients because they often wonder why, and it's one of the biggest complications. They also only had 1 dislocation per group, and this was comparing the DA and the posterior approach. So what about this neuropraxia? This is a great study that actually shows there's A, B, and C types of this lateral femoral cutaneous nerve, and you're bound to hit it at some point, even if you are meticulous, because it kind of webs around the sartorius and then at the point of your incision a little bit medial to the ASIS. Some more complication rates between randomized studies, randomized controlled trials. Basically no difference in complication, OR times, between the approaches. There was a higher risk of aseptic loosening, and this is the Australian Joint Registry at the bottom between 2015 and 2019, and higher risk of femoral fracture within 90 days of the direct anterior approach. And that's probably something that I'm going to hit home on later on. The direct anterior approach, especially early on, there may be longer OR times, more risk of bleeding. And I do think that there are some increased wound complications with the DA approach, but in regards to the posterior approach, I think it would be a little bit ignorant to say that there's higher infection risk. I think that's really dependent on your skill level and the BMI of the patient, as well as other comorbidities. So as that goes up, the other goes up. One of the other things that is a little bit of a risk here is the femoral nerve palsy. I think on the posterior approach, you can kind of say the same with the sciatic nerve. The sciatic nerve palsy is not 0, but femoral nerve palsy here, at least in this study, was 14 times the rate of a posterior approach, which makes sense. But that's a little bit scary because that's something that you don't want to ever have happen. Iliopsoas impingement is a little bit higher complication in the DA approach, and that's something that we have found solutions for. This is a pretty good study by one of my buddies, that basically you need to have that anterior superior rim of the acetabulum less than 8 millimeters off, and you can kind of tell this intraoperatively. You can put your finger in there, make sure it's not retroverted too much, and make sure you're tucked under. And this goes through an algorithm of how to treat that with pretty good success. So there's a steep learning curve, higher complications, revisions. There's all sorts of literature. If you just go on PubMed, you can find this stuff for each different approach. But one of the things that we want to kind of discuss here is the learning curve. And I think that this is really relevant because you ask high volume surgeons and they give you different answers, as we've seen on CCJR and ACUS this year. What's the learning curve for DA? Well, this kind of study shows that if you do over 100 cases, you are in a much lower percent revision rate, whereas if you do less than 15, your cumulative percent revision is pretty high. So I think we need to be training more in residency and fellowship on every approach that we can possibly get our hands on. So here's this study in 2012 that said the substantial learning curve of 60 cases. So then let's talk about dislocation. This is going to be probably a hit for Chris because this is going to be an easy target on my back. If we look at some literature from historical and relatively newer data, we can see that if there is no type of posterior repair in terms of the capsule and short external rotators, our dislocation rate is pretty abysmal. Now, looking at some of these same studies, when they repaired things like the short external rotators and the capsule, the dislocation rate is much lower. And I would advocate that it's probably not 0%, but it's much lower than what it was before. There's registry data. This is the Swedish hip registry. And basically from 1999 to 2006, there's no difference in the risk of reoperation, but there's higher risk of reoperation due to dislocation with the posterior approach. Taking that from 2007 to 14, no significant difference in the risk of reoperation due to dislocation between the two approaches. So here's just another study kind of reiterating that same thing, that if, this is the Michigan statewide registry that's been reported more recently. And basically they did not see any difference in their dislocation risk. So I think that this number can be brought down quite a bit, and it shouldn't be the biggest factor of why people go to the direct anterior approach. Kind of the Achilles heel here that I found with the DA approach in terms of exposure is aseptic loosening and periprosthetic fracture. A lot of this data is going to come from the Australian Joint Registry. If you look at cumulative incidence of revision for all hips, loosening and fracture are up there. And then we look at the direct anterior and the posterior. Here again, I'll focus on the anterior. And it's not necessarily infection or prosthetic dislocation, but it's fracture and loosening. And those if you have a fracture or something's loose, oftentimes require a revision. Here again is percent revision of primaries for anterior, lateral, and posterior. And you can see that the anterior for the diagnosis of loosening is much higher. Here is for fracture, anterior is higher. And these may be small numbers, but they're still relevant. And then to be fair, when you look at dislocation there, the posterior approach is surprisingly, the lateral approach was up there as well, which is not something that I would have necessarily expected. Complications, we're going to kind of look here in the last couple of minutes on aseptic loosening of the stem and periprosthetic fracture. The direct anterior approach is the clear white box. And these are why the DAs fail from this article in 2017. Here again, we can see femoral loosening. So this study showed that the direct anterior approach had a lower dislocation rate, and we've kind of discussed that, but higher risk of revision for aseptic loosening. And this is going to be kind of highlighted again over and over and over again. More studies showing the same. And then periprosthetic fracture, this study showed a fracture rate of 0.83%, increased age, female gender, thinking about more osteoporotic bone, tighter window, smaller exposure. These things make femoral complications much more relevant here, and definitely depending on the stem design, whether you use a single taper or a double taper, that matters. So here's kind of what's the difference for people that haven't seen the direct anterior approach. This is basically the window that you get. There's the ASIS proximally. Here the head and the foot is down. You can see the shaft. This is your femoral broach going in, and you can see you have a tendency to put it in varus flexion and anteversion. And this is challenging because once you start out in that direction, you start broaching a couple times and you think, oh shoot, maybe I don't want to go that way. Then you may have removed the canthallus bone that's giving you that support in the metaphyseal region that you need. So people have admitted to this in a bunch of talks, and it's something crazy that can happen, and I hope that it never happens to me, but you can actually perforate the femur and not really even know it. So you need to really drop your hand down, and this is kind of a devastating complication. You can see that stem, that broach going down out of the femur there. This is pretty old data, but you can even get greater trochanteric fractures with the traction table. You can get ankle fractures. You gotta be careful about this stuff, and you really can't come out hot and heavy on the operating day and just try to whip these things out. You gotta pay attention that this retractor here that goes along the posterior aspect of the trochanter in an osteoporotic woman, you can keep pushing that down to get your exposure better, because you have a small incision, and surely I can imagine you can break that trochanter off, and then you got to do something else, and that's not ideal. So are we truly muscle sparing? Now this isn't me doing this approach here with this, but I can tell you that in these tight incisions, you're getting up to a bigger reamer size, 54, 56 reamer, and you got to get that acetabular reamer out. It is challenging, especially if you're 5'9" or 10, and Dr. Brown is 6'6", and you're at his level. Getting the reamer out is challenging, and you can really bugger up that TFL. And so I think that this is something that we need to be cognizant about. And finally, I'll kind of end it on, these are pretty low numbers, but you can kind of see the trends here. Orange is direct anterior, blue is posterior lateral. And this is on mechanical complications. Days to first complication higher with the DA, days to reoperation higher with the DA, periprosthetic fracture higher with the DA, and loosening higher with the DA. And I apologize that this looks a little bit blurry, but you can see the arrows pointing down are all the decrease incidences versus the posterior lateral approach, DA being higher in terms of all mechanical complications, periprosthetic fracture, aseptic loosening, and then that required return to the operating room in terms of overall periprosthetic fracture and femoral failure all being higher with the direct anterior approach. But to be fair, instability and dislocation was higher in the posterior lateral approach. So to recap, I hope I didn't take too long there, Chris. Any approach requires experience and comfort with that. I think complications decline and patient outcomes are better. They can occur with all approaches, no matter the degree of skill that you have. It's up to the surgeon and the team to understand these respective risks, discuss them with the patient preoperatively, and work to recognize and minimize. I think the posterior approach overall gives great visualization of the femur and the acetabulum. It can be extensile, and dislocation risk can be reduced. The direct anterior approach, I think, is still an awesome approach. It can minimize the dislocation risk, but it should be incorporated earlier into training, as the trend is going to continue to rise, I believe. And we've seen that. The aseptic femoral component loosening, I think, is a big thing. Periprosthetic fractures to some degree, and then neuropraxias, impingement, and the learning curve are all real. So I think as we get more comfortable with this early on, then we can do and then teach better. So thank you.
Awesome. Thanks, Jeremy. We'll move on to Chris, and then we'll save some time for questions here.
All right. I thought this was going to be evidence-based, but then I heard Jeremy imply that he was 5'9" or 10. So I think we all know that's a lie. Let me share my screen here. All right. That's the wrong one. That's for later. Let's do that one. All right. So thank you, Jeremy, for that. My name is Chris Whalen. I'm the other recon fellow coming from Wisconsin. I'm going to talk about the direct anterior approach, give the people what they want. So just my only disclosure is, as Jeremy's pointed out, there's a ton of lower quality evidence out there. So I've cherry picked accordingly to support my argument. Jeremy did a nice job pointing out how the posterior approach provides reliable results. It's sort of the old faithful, and that may be fine for the hip replacement patients of the past, allowed them to, hobble around the house. But I'm going to argue that today's patients are a little different breed that we're talking about. And, I generally thought Jeremy was a pretty smart guy, but I'm surprised he's defending the posterior approach. Maybe he spent too much time in flower fields with his a cappella group or collecting doilies with his wife. But we'll get you learned up today, Jeremy. So touching on some of the history, Carl Hutter in Germany kind of described the anterior approach in 1881. Smith Pete further developed this in the United States. And just a shout out, he was Wisconsin raised, University of Wisconsin as well. The Judet brothers in France used this a lot for fracture work and the acrylic prosthesis. And it was actually their father, also an orthopedic surgeon, who developed the Judet table. Heinz Wagner utilized it for resurfacings in 1978. And initially, this was a pretty big exposure, removing part of the TFL, often sectioning the rectus and piriformis, and so it was pretty morbid. It was around the early 2000s, really started to gain some traction for THA. Rich Berger tried to popularize a 2-incision hip that didn't exactly catch on. But then Kegi and Mata sort of around the same time really started to popularize this. And at this point, it wasn't really involving any release of the muscles or tendons that were originally described. And another name around the same time, Martin Christmer in Germany. Kegi liked to use a standard operating table, which we now refer to as off table. And he used accessory incisions pretty liberally and rarely used fluoro, whereas Mata really popularized the special table single incision approach. So this was kind of the initial exposure, big incision, taking off some of the TFL, dividing some of the rectus. This is Hutter up here, Smith Pete right here. The Judet brothers in France were using this a lot. And then, not really relevant to this talk, but he has such an awesome beard. This was Volkmann, another orthopedic great. So Kegi, this was his original paper. You could see he liked to use accessory incisions, and that allowed him to use the standard straight instruments that were already around. And he published in 2003 on his 20 years of doing this, 6,000 cases. At that time, had a 1.8% dislocation rate. He did have a 5.7% fracture rate, so not insignificant. Mata, I think a lot of us have heard of Mata. He started doing these around 1996 and helped design the Hana table. He learned pretty early in his experience to move the incision a little more lateral than the initial Smith Pete to help protect the lateral femoral cutaneous nerve. And he published on his first 500 hips and found 93+% of them were hitting the target anteversion abduction and within 3 millimeters average of leg length discrepancy. His dislocation rate, even at that point, was 0.6%. As Jeremy pointed out, he had 3 ankle fractures, which he said was pretty early on before they really had things figured out. When we look at how we do this today, using the HANA table, this is kind of our typical setup. You can see the traction boots, perineal post here. We have fluoro come in from the other side. Kind of nice, you only have to prep out a small area of the hip rather than the whole leg. Very easy to position. You have the surgeon and one assistant on the operative side. Fluoro comes across. We'll often have a second assistant, or now we're usually using a self-retaining retractor from across the table. It does require someone to run the leg who's unscrubbed, and that's kind of our typical setup. There are other products out there such as this that allow you to use a standard operating table but still get some of the benefits of the HANA table. And then others like Kegi promote the off-table approach where you can drop the leg of the bed, allowing that external rotation, extension, and adduction. And this also allows you much better testing of stability and leg length without fluoro if you want it. When we look at the approach today, again, that incision is more lateral to the traditional Smith-Peet, much smaller. We rarely cross the groin crease. It's about 2 centimeters distal, 2 centimeters lateral to the ASIS, and you're sort of overlying that anterior portion of the TFL. Come down on the TFL, divide the fascia in line with the incision, and then bluntly dissect into the Smith-Peet interval. Once you're there, you see the fat and then the branches of the lateral femoral circumflex, usually 2 veins and an artery that should be ligated. At this point, you're working between the glute medius and the rectus. And so it's truly an internervous, intermuscular plane. And then we'll make either capsulotomy, capsulectomy in some form such that this is the view you get. We then make an in situ neck cut. So we'll often use a napkin ring, such as shown here. You can use fluoro if desired very easily to determine your neck cut. And then we move on to acetabulum, typical exposure and releases, removing the labrum, and then begin reaming. You generally have a pretty good view of the acetabulum, but if you like, you have the option very easily to use fluoro to ream, which early on is a nice option. And then with checking cut position, again, very easy to look at your anteversion and abduction. And there's certainly multiple different vendors with software that can help you do this, or just eyeballing it, drawing lines, etc. So pretty reliable cut positioning. We then switch over to the femur. So again, gonna place a femoral hook, drop the leg, externally rotate it, drop the leg, and adduct it. And then as Jeremy pointed out in the same slide, this is the view you're getting. We put a retractor around the greater trochanter, and then we begin our releases. And this was a nice study that sort of looked at the hierarchy of releases. We're obviously always doing some form of capsulotomy or capsulectomy. Vast majority of the time, you're releasing that superior capsule going straight north to the greater trochanter. Probably roughly half the time, release the conjoint tendon. And then in the paper, they advocate sort of reevaluating, resetting your retractors at that point if you're still struggling. Sometimes even bringing the leg back up, externally rotating back down. And then very rarely, probably 5% of the time or so, they estimate you release piriformis, and even rarer still, releasing obturator externus. This kind of shows it here. Once the superior capsule is removed, you can kind of make an L around the conjoint tendon, leave the piriformis intact. Once you've done that, we have offset broaches. Again, this is the femoral hook to allow you to broach the femur, as Jeremy said, dropping your hand, and this is stem insertion here. And that's kind of the key, is just getting the femoral exposure. Once you've done that, easy to bring fluoro in, you get a picture, look at your stem fit, look at your leg length offset, all the above. So very nice to have that option for fluoro there if you want it. And then closure is also a breeze with the anterior approach. You could throw some stitches in the capsule if you decided to retain it. And that's just fascia and skin closure, usually pretty small incision, so quicker closure for sure. When we look at the benefits, there's benefits to both the surgeon and the patient. On the surgeon side, I think the supine positioning is easier, and even with the traction table, it's pretty reliable, and you can teach your ancillary staff how to do it relatively easily. You know, it's pretty easy to just lay someone level on the table. It's a lot harder to get the pelvis level lateral. Fluoro, again, is super easy. Just bring it right in as much or as little as you need it. We'll talk some about the marketing and then some of the patient benefits. Jeremy, kind of glossed over this, how easy the posterior positioning is, but we've all used these positioners, or I use the pegboard in residency a lot. And you think you got it great, and then you're in there and it's just not looking right, or you get an intraop X-ray and realize you were way off of where you thought. This group that did robotic surgery looked at where their cup would be initially, and then once they brought the robot in, and over 40% of them would have been off by more than 5 degrees, just based on that positioning. So I think the supine positioning allows for a more reliable, reproducible, and rigid fixation. And it's also kind of easy when you're learning to understand the cup position when you're in the supine position. That's how we sort of think about it as we're learning. Does the fluoro matter compared to a non-guided posterior approach? Yeah, it did a little better, 97, 98% in target versus 77 to 86%. Another group, 99% versus 90%. This was a paper out of the Mayo Clinic. Jeremy himself was on this one, looking at 2 different ways of doing the anterior, so on table with fluoro, off table without fluoro. And they found the results were great in both groups, but no different. So you can really use as much or as little fluoro as you want. And I think that's extremely beneficial, especially during that learning curve. What about the marketing side? There's certainly a lot of marketing out there directed at the patient and at the surgeon. This was just one article I found. More active patients want a less invasive technique, quicker recovery. This came out of a website from one of my future competitors in Wisconsin. Advantages of the anterior hip. All these things. I mean, I think every patient wants a shorter hospital stay, less trauma, less pain, etc. You have no restrictions. It doesn't mention that most people don't do restrictions for posterior approach, but get back to your yoga and such much quicker. Recovery's faster. This is kind of a nice one. It's more complex and fewer skilled surgeons, and it's kind of nice. It kind of paints a dim-witted picture of all your posterior colleagues and creates some exclusivity around the anterior approach. Makes it seem like anybody can do the posterior approach. And just to test that, I taught my sons how to do it just this past weekend, and within a few minutes they had it figured out, other than putting the femur in upside down. But pretty easy approach. This one I especially liked, incision 2 to 5 inches long for the anterior approach. So I'd like to watch that 2-inch anterior approach incision. But at any rate, these are out there, patients see it, and it's hard to, contradict these claims in a concise manner, a quick one-liner that patients are really going to understand. I do think enabling technologies such as robotics and navigation, et cetera, make that easier. If you market a robotic posterior approach, maybe that'll overtake an anterior approach. But it also, by doing this anterior approach, I do think you attract a little healthier population to your practice, which may not be the worst thing. It's funny, Jeremy brought up the cars. I sort of think of it this way: if you're a car salesman and someone like Jeremy here comes in wanting to buy the new Ferrari, are you really going to talk them into the used Subaru you got standing out there on the lot? I don't think so. Well, is there some data out there on patient preference? Here was not the best study, but some patients, single surgeon, who initially underwent one side posterior and then later on went anterior on the other side. 70% preferred that anterior, 81% said it was easier recovery. Mayo Clinic did a survey on new hip arthritis patients. Only about 30% knew of DA, and this was around 2016, 2017. But of those, 70% agreed it was less painful, less time on a cane, less tissue damage, faster return to work, shorter stay. And actually 30% felt it was a consensus among surgeons that DA was best. Jeremy brought up some of the AUKUS data. This one actually said 56% at AUKUS do some DA, but 76% reported increased market share because of it, and 66% of non-performers reported they lost market share because of it. Interestingly, only 3% were going to change. And then this was just data I observed this year. It was equal amounts, 45% anterior and posterior. Interesting, again, small numbers, but 25% of surgeons in this survey had tried DA and abandoned. So some of the other benefits we'll go through: the less trauma, faster recovery. Jeremy touched on dislocation, and then we'll look at some of the long term. So Jeremy brought up this study. I'll just point out it was It was done at Mayo on six dead people. So not exactly the biggest numbers, but difference is the posterior beat up the minimus a little more. Obviously, the transected piriformis and conjoint in all of them. Piriformis was 33% in anterior, conjoint 50% in anterior. And then the DA beat up the TFL, which I think we know. Well, what about in real living patients? This was a serologic study, and they found that the CK rise was over 5 times higher in the PACU and posterior approach, and the inflammatory markers were slightly higher as well. I don't know that that means anything clinically, but some evidence that the muscle's getting more beat up posteriorly. And what about all this soft tissue stuff, the soft tissue repair? This was a planned MRI study on 32 DAs at discharge. And at discharge, 75% of piriformis were still intact, 38% of conjoint intact. At 1 year, 97% of piriformis and conjoint tendon had healed down to bone, and the posterior capsule was intact to bone in all. The capsulotomy and repair group, none had persistent defects. This was not as great a study. These were opportunistic MRIs, so the patients had some pathology to warrant an MRI, but of those, 48%, and this was a posterior hip group, had some form of posterior capsule dehiscence and a higher rate of dislocation in that group. Planned MRI study in posterior hips, capsule was intact in 90%, which is high, but that's still 10% who don't even have capsule intact. And then about half of the piriformis and conjoint tendons had a persistent gap of 2.5 centimeters. So kind of questionable if that's going to heal down. I'm sure it'll scar in some fashion, but what about the recovery? This was a non-randomized study. Anterior had faster timed up and go tests at 2 weeks, no difference long-term. Randomized study looking at gait analysis. This was versus the anterolateral, but the DA had improvement at 6 weeks and continued to improve at a faster rate at 6 to 12. Randomized study again versus the lateral. DA was better up to 1 year in some of our standard metrics. Randomized DA versus posterior, single surgeon. DA had lower pain, more patients climbing stairs normally and walking unlimited 6 weeks, better HOOS at 3 months, no difference at the later time points. Single surgeon looking at his last 50 posterior hips to his initial 50 DAs and his next 50, and the DAs had better short-term results, lower pain. Jeremy brought this one up. I think it's an interesting study that's quoted a lot and used to defend both points, but 100 patients randomized DA or posterior at Mayo Clinic. Very good surgeons performing both approaches. And the DA got off their walker cane a week sooner and was doing more steps, and no difference otherwise. So, the posterior guys point to this and say there's no difference long term, but I think from a patient perspective, if you tell them that there's no difference long term and they're going to do better in the short term, I think you know which way patients are going to go. And Dr. Ton did a very similar study at Ortho Carolina, again showing 1 week sooner off gait aids. Dislocation, Jeremy kind of beat this to death, but this is a retrospective review. Anterior approach 0.6 in the DA versus almost 3% in the posterior group. And even in patients with spinal pathology, much better in the DA group. Curley and Clinic published or presented this at ACUS this year. They looked at their DAs, almost 3,000 of them, 0.38% overall at 1 year in the DA group. But for those who had completed their learning curve, it was 0.15%. And even in patients with spine pathology, 0.3%. So very, very low rates. Almost 6,000 patient review, 0.95%. That was back in 2013. This was a huge study out of Rothman, looking at all of their patients, all of their approaches. Dislocation rate 0.74 for the DA versus 1.74 for posterior, including a soft tissue repair. So I think people often just say, oh, the dislocation stuff was before soft tissue repair and brush it aside. I don't think that's entirely correct. I just point out direct lateral had the lowest dislocation rate of all. Registry data, Jeremy pointed out, the Dutch registry lower in anterior and lateral based approaches. When you looked at non-dislocation reasons, posterior did have a lower risk of revision. So in a lot of these registries, the dislocations are sort of evened out by the fracture and loosening risk. So a lot of times the overall revision risk is pretty similar. But in a subgroup less than 55, the overall revision risk was much less for the anterior. Norwegian registry, very similar results. Australian registry, as Jeremy pointed out, no difference in overall revision at 4 years. The DA did have higher femoral complications, but that was offset by actually lower infection in the anterior approach, lower revision for infection, and lower revision for dislocation in the anterior approach. What about in the United States? Kaiser data, a little older, no difference overall, anterior, less dislocation. Updated actually did have a lower risk of revision for the DA, 1.78 versus 2.28. Lower dislocations, lower revision for dislocation. They actually had a lower revision for periprosthetic fracture in that Kaiser study, but a higher revision risk for aseptic loosening. So maybe they're just undersizing and not hitting their stems as hard in California. I don't know. Well, if we try and put it all together, look at some systematic reviews, pretty consistently, they say DA has evidence to be favored in the short term, no difference in the long term. And this study looked at time and saw it did take longer on average. Well, what about some of Jeremy's claims, some of the cons? We'll kind of tackle some of that. There's no way around it. There is a learning curve. I would argue there's a learning curve to the posterior approach as well. We just do so many more of them in training that we're way past it by the time we get out. It does, in most people's hands requires a special table and a trained staff to run. Although, in residency, we just had our circulator do that, and it really wasn't a big deal. So I think you can train them pretty easily. What about the idea that you can't or you don't really want to do revisions or you have to use certain implant options? We'll talk a little bit about appropriateness, and I think this evolves as you get more comfortable with the approach. But patients that are going to be tough are elevated BMI, having a wide iliac wing, acetabular protrusio, valgus neck, muscular males. And then anytime you got to do anything on the posterior column, anterior is probably not the way to go. We'll talk about some of the wound problems, nerve problems, and overall outcomes. So I think the learning curve, really came to a fore when studies like this came out. 5 surgeons just out in the community hacking out their first couple anterior hips, and they were taking 2.5 hours, losing almost a liter of blood, had a huge major complication rate. Even they had 0 dislocations, but still, it's kind of scary. But then more and more studies come out, and these were more experienced surgeons. This was Ortho Carolina, as one of the surgeons switched to DA. And he found after about 100 cases, his operative time in fluoros had significantly decreased. He had no fractures after 62 cases, no infections in any of them. And he saw benefits in cup position, dislocation rate, and limb length discrepancy from the get-go. And I think that's just a function of easy fluoroscopy. Columbus, Ohio, their group estimated it takes about 40 cases or 6 months in a joints arthroplasty practice. Utah, another posterior surgeon who switched to anterior, and he really found no difference in operative time, complications, or patient outcomes, even in the initial patients. The Australian registry actually looked at learning curve based on revision rate, as Jeremy pointed out. And once you get to about 50 cases, you're pretty close. And then as Jeremy showed, 100 cases, you kind of plateau out. So that learning curve, probably somewhere in the 50 to 100. I think compared to a posterior approach, a non-guided posterior approach, the anterior is always going to take a little longer. I would estimate probably 5 to 10 minutes. If you're doing intraoperative x-rays routinely or using a robot, I think you can get the operative time pretty equivalent. As we mentioned, it does require someone to run the table, or you can do an off table. I think the benefits in cup position are seen right away. And just to put numbers in perspective, I'm on track to have about 100 DAs by the end of my fellowship year with my residency experience. So I think this data is going to change as we get more and more people who are getting significantly through their learning curve during their training. The fracture risk, this review showed overall probably about 2.3% and certainly higher during the learning curve. The registry data is a little mixed. As I pointed out, Kaiser actually had lower femoral fracture risk in the anterior. But when you combine that with loosening, that rates are surely higher in DA. As Jeremy pointed out, it's pretty easy, especially early on, to undersize and varicize your stem. But I think if you're using fluoro, you should ideally catch that, prevent it. I think, using cement in the elderly patients, osteoporotic patients, there's some data on collared stems decreasing fracture risk, certainly data on non-blade type stems decreasing fracture risk. But ultimately, I think it all comes down to a good exposure, and that's a function of the learning curve. I think if you get adequate exposure, using the same stem, there's not really a great reason you should have a higher fracture risk in the anterior versus the posterior. So I think it really is a function of exposure and a lot of people trying to use more of these less invasive blade type stems. So summed up, I think it is a modifiable risk by the surgeon as you get through your learning curve and also think about your stem choice and cement. I do think that number can come down. If it happens intra-op or if it's caught intra-op, you can address it relatively easily with cables, protect the weight bearing, and usually no long-term sequela. And then as Jeremy pointed out, there are perforations. They seem to be rare. In some of the webinars I've seen with like Bill Hamilton, he said he can usually just bypass it with a standard stem and hasn't really had to change anything. It hasn't proven to be a big problem. Obviously pretty scary if it happens. What about some of these revisions, complex cases? It's certainly attractive in some ways. We know with the revision of total hip, the biggest overall problem is going to be instability. So if you can maintain that posterior capsule integrity, I think there's some reasons to like that. Not necessarily advocating though. I think this would be fairly difficult. You'd want to be pretty comfortable with your anterior approach. We did this in the lab not too long ago, but you can do it. This was one group who published on a subtroch osteotomy anterior approach. This was acetabular only revision. You can flex up your hip, externally rotate it, get a retractor over the neck, and address your cup. They make certain offset instruments that can help with that. I thought this was a particularly interesting case off of UMedi out of the Utah group. They converted a nail to a tapered fluted modular stem. And they took the nail out and then reamed through that same incision. And they did this supine. They did not have to elevate the femur like we typically do during an anterior approach. And then they did their normal anterior approach to place the cup and final, body and trial. And, not that I'm necessarily advocating for it, but it certainly can be done. And I think as you get more experience, it may make more sense to do some of this. They felt like they were able to maintain the posterior capsule and still bypass the screw hole, get a good stem, and use fluoro easily. So it can be done, not necessarily advocating it. The wound issues, I think this paper in particular certainly scared people. This was out of NYU, and they looked at all of their hips and found over 2 times higher risk of PJI, so infection in the DA group. But when you look at their actual data, the anterior rate was sort of all over the map here. And so I think it's a little hard to extrapolate this single institution data. I think the registry data certainly does not show a higher risk of septic revisions in the anterior group. The only study that showed a difference actually was less in the anterior group. That was the Australian registry. But I do think wound issues are real. Some people will use an abdominal binder to help keep the pannus off, or things like incisional vacs, etc. But certainly simple wound complications, superficial wound complications do seem to be higher. This group did a receiver operating curve and suggested that a BMI of 28, much lower than we typically think about, was a cutoff or inflection point for wound issues. And that may be an argument for more selective DA, but something to think about. Another study, again, no difference in deep infection, but higher rate of wound complications in the DA group, but not actually a difference in reoperation for those complications. So it's out there. Well, when we talk about the wound, what about cosmesis? Again, I think we're seeing a younger active population. This guy, do you think he really wants a big old swooshy scar on his butt? Or do you think he wants a nice, sexy bikini incision for an anterior approach such as this? Look at how happy that guy is with that tiny little bikini incision. Lastly, the nerve issues. Jeremy touched on this. The lateral femorocutaneous nerve is certainly a real phenomena. maybe upwards of 80% at the initial visit, but has not been shown to cause any decrease in functional outcome, patient-reported outcomes. So I think you kind of give patients a heads up that they're going to have a numb patch of some size. Most of the time it's pretty small. Again, as we move that incision a little more lateral over the TFL, it's certainly become much less. The femoral nerve palsy is real. This was a large series, 0.2%, much higher than posterior, not surprisingly. But again, I think is offset somewhat by the sciatic nerve risk in the posterior. My anecdotal N of 1, I've had 1 femoral nerve palsy in a posterior approach and 0 in an anterior approach. So high quality level 7 evidence there. I think just being careful with your placement of your anterior retractor, doing expeditious surgery, careful how hard you're pulling on your retractors, and then keeping your incision a little lateral. Jeremy kind of showed this anatomy, but again, if you keep your incision more lateral over the TFL and a little more distal, so you're in this plane till you get under the fascia, then work over to the interval, you're going to do a lot better. So in summary, I think if you do a good job, vast majority of patients are going to be happy regardless of approach. There's likely an early benefit that's real in the DA without a long-term difference. Dislocation is likely slightly lower, though, as we pointed out, with modern techniques and things like dual mobility, robotics, navigation, etc., I think those numbers are going to be very small in both groups. The femoral fracture risk and loosening risk is real, particularly in the learning curve. But I think as people are getting through their learning curve in training, and as we're improving our techniques, I think that risk is going to come down, similar to how dislocation came down in posterior approach. The wound problems are probably real. I think just, the careful soft tissue handling, maybe the abdominal binders selectively, maybe wound vac selectively, etc. We know there's a subset of patients who definitely want DAA. And I think with all the data on psychology in outcomes, I think we should give people what they want. It's marketable. And just my personal belief, I don't believe all primary joints should be done via DA approach, certainly not early on. I think there's good evidence that an individualized approach may be best. Unfortunately, the patients, that are at highest risk for complications with the posterior approach are the same patients at highest risk for complications with the anterior approach. But I think you kind of need to pick your poison. So with that, I'd like to say thank you. And Jeremy, buddy, hopefully I didn't leave you crying too much. So thanks, guys.
Great job.
Excellent, man. That was excellent talk for both of you. Thank you for doing that. As a disclaimer, that was my picture, but that was Chris's suit on that one shot towards the end, just if anyone had any question on where that bathing suit came from. I want to make a couple comments. I adopted DA not because I was zealot and thought it was better, but thought that it needed to be something that residents and fellows were exposed to early on. And honestly, it has a big bearing on the marketability of the fellowship itself. It's been a difficult journey for me to do that. I had never even seen or done a Smith-Peterson approach as a resident or as an attending, and was born and raised on posterior approach and still do a lot of posterior approach. Patients ask me, why do you DA is better? And so and my response is DAA is not better or worse. It's just merely different, and it has its own inherent advantages and disadvantages. And so it should just be another tool in your toolbox, or another arrow in your quiver that you might be able to take advantage of. Dr. Hansen at Mayo Clinic had described a total hip as a bunker buster. And for those of you who are not aware of it, a bunker buster essentially is a bomb that goes underneath the ground and detonates below the surface. And that's what a total hip is, regardless if you're doing it from the front or the back. And so it depends on how good your soft tissue technique, regardless of its anterior or posterior, on how much tissue trauma you're going to induce during the procedure. One of the things I think important thing is just don't change your stem and your approach at the same time. I think you need to become very facile with a stem, and then use that if you are going to change or adopt a different approach to try to minimize the complications. And I think I still do more, I'm more invasive from the front, if you to look at it that way, to make sure that I can see what we need to see and not rely on fluoro. I think JB Trey and myself have all seen some disasters from anterior hips that were attempted in people that both by surgeons who probably shouldn't be doing, and in patients that were not great candidates for it and had horrendous complications from not being able to visualize what they needed to see, and caused horrendous acetabular and femoral problems. Don't think I have anything else. Any comments from JB or Trey before we sign off?
Well,
Or any questions from the audience?
that's a great comment. I think, end of the day, it's really up to the surgeon and also the patient choice. I think Chris made a great comment on that, individualized approach. So you do see, the good surgeon knows, how to do surgery, but a great surgeon know, when not to do surgery. So that's the idea. It has to be, really familiarized with your skill, your technique, and also you need to know your patient. That will dictate outcome. So, I do have a question. You both did a great job, but you find any data actually talking about a surgeon burn out? By doing anterior hip approach, many surgeons talking about it cannot sleep well. And, challenging, definitely more challenging, spend more time in the operating room, blood loss can be a bit more. You look at a nerve injury and hardware, got a problem. Those are, it's real, like what, you guys talking about. We see, talk to many surgeons doing anterior hip, they always talking about, yeah, we have to do it. It's a marketing tool. You can definitely bring patient back to your practice, but you do struggle. You have to choose the right patient. We have seen, surgeons actually quit doing anterior hip, but not only just 5%. They tried, but people have done many years, and then later on they just cannot handle that anymore. So I'm just wondering some data there talking about why, the surgeon burn out.
I didn't see any data so much on the why, other than that ACUS data where they just pointed out the surgeons who weren't interested in the DA, they felt that it just wasn't, the clinical outcomes weren't there, and the learning curve was a big detractor. I don't think it's been well studied, but I do, as I highlighted, I think that ACUS stat that 25% had tried and quit kind of puts it out there. And I think Jeremy and I have seen this. The DA approach, you have some great days and you love it. And then you have one case where you just struggle, and the whole time you're thinking, if I was just doing this posterior, I'd be done and I'd be a lot happier right now. So I can certainly see that.
Yeah, I think kind of Tom Brown always says, Chris, how does it go? Our most recent complications dictate, the next act, or how we're going to perceive something next. And I think Chris nailed it. There are a couple days here or there, or a couple times here or there with the direct anterior approach where you're just like, gosh, this should be so much easier, and it's not. Even though the patient's thin and we have the right everything, it's harder. And it'll only take, one time to make you think, God, why am I doing it this way? And could it have been easier through the other side? So I think that I don't know the data on burnout, but I think that early on in your career, especially like me and Chris, if we get to that point, which I can foresee, definitely me having my own struggles with that you could burn out and be nervous and go home every night like, oh my gosh, is my stem loose? Why did it take me 8 hours to do 3 cases when the person, my competition did 9 cases that day? And that can be pretty exhausting. But from the people that I know that are really good surgeons that have tried the direct anterior and gone back to the posterior, it's not necessarily because they couldn't do it. It's because that the posterior approach for them was faster, it was easier, and it didn't solve a problem for them. It didn't give them better outcomes or lower dislocation rate, because they were already very good and proficient and efficient at the posterior approach. That they said, well, you know, I've been doing this for years. I'm better at it, and I don't have any problem being solved.
Ask a question to the two fellows.
Oh.
Yeah. So your first 10 hip replacements in practice, how are you gonna assign them up? Are you gonna recommend anterior, posterior? Like, what is it gonna be like when you start practice?
Yeah, I think, well, I'm going to cherry pick. So if they have, you know, I'm going to go through a checklist radiographically of the patient's morphology, how thin they are, what comorbidities they have. Are they a thin person with a kind of a fat belly that hangs over? I'm going to really probably try to cherry pick, or that would be the goal, or I'm going to be kind of forced into a position where if the rest of the community is doing direct anterior, then I need to try to jump on board to some degree, because I can't be the only person that is not doing it. That would be the less book answer, but I think that does play a part in decision making to some degree.
What about you, Chris?
Yeah, I think similar, although I'm a little more on the fence on if I'm going to do DA at all. I already know I'm going to a market that's not, I'm not going to have to necessarily compete in that sense. I'll have a big referral base. So if I do decide to do DA, it's going to be very selective initially, at least.
I've heard Dr. Brown is so good at Zoom that you can just zoom into your OR with Dr. Tom Brown. He'll walk you through it if you get in trouble. Okay.
All right.
He's out for that.
So guys, great job. You know, very, very well done. Usually this is, you know, in person. We do it in a basement somewhere, sort of like Fight Club. You know, we go bare knuckle at each other. And so it's a little different this year on, you know, on Zoom, but you both did a great job. I think that last discussion really summarizes it well. You know, I mean, I think if most people, given the choice to do what they think is best, without the pressures of marketing, you know, will make one decision, and they might make a decision differently based on other factors, which you can debate whether or not that's a good thing. I think if you look at the literature, I mean, I PubMeded anterior posterior total hip arthroplasty, and there are over 1,000 articles on this topic last year. I think the topic's really been, you know, beaten to death. You both quoted the Mayo study, Mike Taunton's study, suggesting a slightly quicker return to function with the anterior approach. But if you look at it, you know, you can torture that data however you want. There's a study that received the AUKUS Clinical Research Award last year looking at the minimal clinically important difference and the patient acceptable symptom scale, or state, I should say, the PASS. And if you look at it that way, you know, how many patients actually achieve their goal? There seemed to be some benefit to the posterior approach. So I don't know that the jury is quite out yet in terms of even early recovery. You can find papers that go both ways. Certainly when we see patients in clinic at 6 weeks, I mean, they're doing incredibly well. Hip replacement is a great operation. And you ask yourself, should we be taking risk? I mean, we have an operation that works well. We really ideally want to take risk where the risk is needed. And I would argue it's not a great place to take risk in primary total hip arthroplasty at this point. Tom summarized it very well. You know, we have a large referral practice here, and we see a lot of potentially avoidable complications, really devastating complications from the anterior approach. And a lot of the studies that look at, you know, average outcomes sometimes neglect the outliers. And if you're an outlier and you have one of these devastating complications that could have been avoided, it can be a life-changing event. I've got several in my practice that had potentially avoidable complications that occurred from the anterior approach that are not solvable. And so you have to decide, you know, is the risk worth it? And you know, that's where the debate goes. I think one of the things that keeps fueling this debate is the somewhat irritating nature of the surgeon marketing, as you highlighted, both of you highlighted in your talks. And, you know, that sort of used car salesman, misleading website stuff that really sort of irritates a lot of posterior approach surgeons. And I think, honestly, if a lot of that went away, this would become sort of like the PSCR total knee debate, where it wouldn't be quite as emotional. But great job, guys. You know, obviously, Chris, you were assigned the losing topic, but you did a good job trying to defend what's a somewhat indefensible point. So congratulations.
Thank you.
I'm not sure we can trust a man wearing a mask on Zoom, but we'll take that. We'll take that for what it's worth. There was a couple of questions here. I did want to mention.
I'm rounding on my patients, Tom. You know, I do with the posterior approach. Actually, I have inpatients, and so I have to see them. Unlike all the anterior approach guys who tell me that you know, their patients stay in the hospital 1 hour and you know, they're home and walking around without a walker
Tom's
that
patients are
afternoon.
at home walking around.
Yeah, I know exactly. So I still have the occasional inpatient, so I've got to go see some folks in the hospital.
All right, thank you. There was one question from the audience. Is the type of approach determined by how active the patient's lifestyle will be moving forward? And I will say that I do that to some extent in terms of if someone is a horseback rider or something else, but I think the others would say that it really doesn't matter. If the components are put in well and you have good stability intraoperatively, that there really is no restrictions to activity once they have healed up. I think we've kind of clarified that, you know, hip precautions are a thing of the past, and we do it more to, it's kind of something that's been kind of fostered by some of the therapists, honestly, that work in home health, that they can't do certain things. And I think if the hip is stable, that those things are unnecessary.
I agree, Tom. I couldn't agree more. I've got to run and see a patient here, but I couldn't agree more. You know, that these misperceptions and myths are fueled by patient websites and physical therapists who really don't understand, you know, some of these issues. There again, as was pointed out, there may be a certain patient who's a slightly higher risk for dislocation who might benefit from an anteriorly based approach. Honestly, maybe they'd benefit from a direct lateral approach. But in terms of activity levels and functions and long-term outcomes, and you know, it's silly to think that the approach would somehow impact functional levels after total hip arthroplasty.
I'll finish with one last comment. I had one of my fellows text me after his first DA hip. I said, I just did my first DA hip, took me 2.5 hours, and I'm glad I got through it. And my reply to him is, say, don't worry, after your first 200, you'll still hate it. Are there any other questions from the audience before we sign? Again, thanks very much. That was outstanding information and relatively unbiased, honestly, from both you guys. So I appreciate you doing that. And if there are no other questions, we'll call it a day. And everyone be safe in the snow if it actually hits for our blizzard of 2020.
Thanks a lot, guys. That was great. As someone who doesn't need hip replacements, I got a lot out of that. And there are a lot of physical therapists here, so thank you all for joining us too.
Yes, it was awesome.
Thanks,
Thank
guys.
you.
All right, everyone be safe.
Winston, your question about your comment on there, I don't think hip arthroscope is going to get rid of a total hip. Trust me, I can bet you a few bucks on there. It's no problem.
All right. Well, 10 years, I'll buy you a beer if there's still total hips going on, okay?
All right.
All right. Take care.
Thank you.
Conversion total hips then.
Yeah, see you guys.